Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research based information about cancers and their treatments.
Hello, I'm your host, Dr. Prasadraj Dandekar. I'm an oncologist and I head the Radiation Oncology Department at Sir H. Reliance Foundation in Mumbai. Today, we are here to talk about a very important cancer that we see very often in India, throat cancer. A very much dreaded cancer because that's a cancer which makes you lose your voice, one of the most important things in our life. And to discuss this cancer and how we can treat this cancer without losing the voice, we have Dr. Shreerang Bhide with us. Dr. Shreerang Bhide is a clinical oncologist who specializes in cancers of the head and neck region, and he's working at the Royal Marsden Hospital in London, one of the most premium institutes in the world. And Dr. Shreerang Bhide is really an authority when it comes to non-surgical treatments of the throat cancers. Welcome, Dr. Shreerang.
Hi, Dr. Prasad.
So thanks, Shri. I mean, I'm going to call you Shri because
That's fine.
we worked together in the
Yes.
past, and when I was in Marsden for 2 years, Shreerang was my senior, and was amazing working with him through that period. So Shri, I was always curious. You're a Mumbai boy, and now you are a consultant in one of the most premium institutes in the world. How was this journey? What made you land there?
So, although I grew up in Mumbai, I did my MBBS from Pune. And then while doing my MBBS, I wanted to delve deeper into the science behind why certain things happen in a patient and why we treat them in a certain way. So I was always interested in doing research along with postgraduate training, and which at that point in India, there were very limited opportunities for doing so. So hence, on recommendation of one of my lecturers at my medical college, I uh, came to the UK and undertook my training. And then while I was working on the wards here, I realized that cancer patients are not very well looked after. And I wanted to help cancer patients in terms of their treatment. And so I specialized as an oncologist. And then while working as an oncologist, I thought head and neck cancer was really very exciting and interesting. And I did a PhD at the Royal Marsden Hospital looking at new treatment techniques using radiotherapy for head and neck cancer. And I'm been a consultant at the Royal Marsden now for nearly 20 years.
That's fantastic. And Shri, you've chosen also a topic which is very close to the Indian population because it unfortunately happens to be one of the commonest cancers we see in India because of the smoking as well as tobacco chewing. And it's really a dreaded disease. And your contribution in research is amazing. I keep seeing all the publications that you're having. And you're also part of the passport trial, which really changed the way we deliver radiation to head and neck cancer patients. And we'll discuss about passport trial also as we go along. So, Shri, in the clinic, what I normally see here in India is laryngeal cancer incidence is increasing because the smoking is still a big problem when it comes to India. I think in the Western world, the smoking incidence is going down, but here it's still a big problem. What sort of population do you see? What sort of patients do you see in your clinic when it comes to laryngeal cancers?
I think majority of the population that I see right now, I would say would be over the age of 75. They are predominantly men, and they have been lifelong smokers usually, or have or started smoking when they were teenagers, when the dangers of smoking weren't as publicized as they are now, and they have given up smoking maybe a few years ago or even a few decades ago, but before they give up smoking, they've always been heavy smokers. So that's the kind of population we are increasingly seeing. We do get occasional young patients, but predominantly they're all over 75.
So that's an important point, Shri, you're making here, that even after stopping smoking, the risk of developing cancer still remains for decades to come, and which is sometimes very difficult for us to, explain to our patients that, you tell them, oh, they feel that once they stop smoking, they are completely free and their risk is as low as the person who's not smoked. Um, what do you think about the reduction in the risk in developing cancer in patients who are smoking?
Uh, I think there is definitely a risk reduction, but it never goes away completely. And the reason for that is what causes cancer. I mean, cancer is basically uncontrolled growth of cells of a particular part of the body. And the reason they grow in an uncontrolled manner is because there are mutations in the DNA that mean that the cell cannot control the growth, and hence patients get cancer from this. Now, smoking is a well known carcinogen in that it results in mutations in DNA in a person who smokes. And these mutations, although repaired majority of the times, some of these mutations persist for a number of years. And some other event in the patient's life, for example, excessive exposure to pollution or alcohol intake, then results in further mutations in more cells. And at the point which there comes a point where these cells are not able to rein themselves in, and they start growing in an uncontrolled manner, and that's when a person gets cancer. So the point I'm making is the mutations that this smoking causes, they never go away.
Yeah. You spoke about pollution, which in India is a huge problem. I mean, London, where you are in the UK, is blessed with beautiful air. Um, but here in India, we do have a lot of vehicular pollution, a lot of industrial pollution, the air quality. I mean, if you look at Delhi, for example, it's like just terrible. I live in Mumbai, which is also quite bad. So we do see a number of patients coming up with various elements of the lungs, including lung cancer, throat cancers, and some of them are possibly linked to the pollution in the air. Another interesting thing, Shri, that I'm seeing here is we are getting patients, a lot of them with voice abuse. So earlier our thought was that throat cancer can happen in people who abuse their voice. So, like teachers, professors who speak for a long time, or singers who are not very well trained and are abusing their voice. But I am increasingly seeing patients who are actually having voice abuse because of their profession. So, recently I saw a patient who works in a factory. He's a supervisor in the factory, and it's a very noisy floor. So, he has to communicate with his colleagues, and to do that, the only way he can communicate is to shout. And that has led to cancer. And when I sort of, his point was, I have never smoked. I have a very healthy lifestyle. I'm a vegetarian. Why do I have cancer? And when I explained him this, he was almost heartbroken. He's like, I am getting cancer because of the job I have. This is just so terrible, because he also knows that he needs to continue doing that job, because that's the skill that he has built over a period of time, and he can't transfer that skill to something else. So it was really difficult. That was a very difficult conversation to have.
Yeah, I can understand. I mean, voice. I mean, we don't see that that often in the UK, and the reason is, I mean, possibly there might be an element of pollution here, because from what I know and my knowledge, I mean, vocal abuse or abuse of vocal cords, voice abuse, can lead to polyps in vocal cords, which are usually benign. But like I've said before, if you've got something else going on, some other insult on your DNA, like pollution, or even this person who worked in a factory, I mean, we really don't know what kind of fumes he inhaled on a day-to-day basis, which might have then resulted in transformation of these possible benign polyps that he had on the vocal cord as a result of speaking loudly day in and day out into malignant conditions. So the answer is we don't know enough, and I think we have to look at other factors in smokers, such as pollution, like we've spoken to, or even exposure to toxic fumes in a working environment.
Yeah, yeah. I think the smoking is really the worst of them, because even when you stop smoking, as you said, it will take many years for it to heal.
And
And years ago, when I just started training, the main treatment for laryngeal cancers back then was essentially surgery. It was entirely the surgeon's domain. And I still remember, it used to look really scary back then, because the surgical skills were also very primitive. You had this patients with laryngeal or throat cancer having surgery with those large tracheostomies, and they would be emaciated, and they would have those big ugly surgical scars, really difficult patients to see. And we have moved quite a lot from there, and now we are here talking about non-surgical management of throat cancers. What have you seen in your clinic? How has this journey been from surgical to non-surgical?
Yeah, I think it all stems from where the cancer is, to be honest, and the function of the organ, or the function that the organ has. So, in case of laryngeal cancer, I mean, it's a very important function for almost all people. That is voice, and so loss of voice can be very traumatic to a person, because they lose their ability to communicate completely. And even though you can do voice rehabilitation with speaking valves and other maneuvers, it requires a lot of motivation and rehabilitation before a person can communicate effectively using those strategies. So we have increasingly moved towards organ preservation, and this started with the veteran study, as you're aware, in the 1990s from the United States of America, where initially actually they started by giving really patients with really advanced laryngeal cancers chemotherapy to try and see if the cancer responded. And in those patients in whom the cancer responded, they gave radiotherapy. And then in those in whom the cancer did not shrink after chemotherapy, they went on to have a surgery, which was laryngectomy at that point. And what they observed, interestingly, was that in people who did not have surgery, that is kept their voice box, the probability that they would preserve their larynx for the rest of their life was about 60 to 70%, which is a huge number of patients. More than half the patients were able to keep their larynx, and at the same time were cured of the cancer and had a significantly better quality of life. So this historic study was published in the early 90s in the New England Journal of Medicine, as you know, which is a premier journal. And then following on from that, evidence has evolved. And we are gradually moving towards organ preservation, even with surgery for that matter. And you did mention that the possible surgical skills were primitive. I wouldn't say that. I mean, you'd displease your surgical colleagues by saying that. I would say the surgical equipment was primitive in that they did not have access to minimally invasive surgery, for example, transoral laser resection, or nasoendoscopic surgery, and now even robotic surgery, which is increasingly being used for laryngeal cancer. So there are options, both using surgery and non-surgical treatment for voice preservation, which is the cornerstone of how we plan treatment for these patients.
So, Shri, just a few days ago, I saw one patient who had an advanced laryngeal cancer, had had surgery, and then had radiation with me. And he was on follow-up. And actually, his wife was one who was saying that the patient's behavior has changed. He gets very angry very soon. And then we discovered, because his valve was not working, so he had to write down everything. So all the communication was by writing it down. And I think that was really frustrating him, and that was causing the anger. So we had to refer him to a counselor, a psychiatrist, and get him through all this. And basically, that's what I wanted to highlight, that what you said about voice preservation, that it's not just the voice, but it's the entire life changes once you lose your voice. Your ability to communicate, your ability to also be included in your family and your circle completely changes. And it's really very sad to lose this important organ.
No, absolutely, I agree. Because I mean, it's just like you said, it's not just communication with your family. I mean, if it is a working individual, depending on what their job is, they could lose their job. For example, if it's a teacher or someone who has to speak a lot for their profession, they cannot do their jobs effectively. If they're a social person, socializing with friends, going out to restaurants or wherever, they feel excluded because they cannot communicate effectively in a public environment. So it's a very important consideration. And I feel that sometimes, I mean, when an option is given to the patient that they need surgery immediately for kind of cancer, which is a life-threatening condition, uh, is enough time being given to the patient to consider the implications of what they are going through? Because There are a couple of points I like to raise here about this, though. So, I mean, first and foremost, in this voice preservation or organ preservation approach, and this is increasingly coming up as an issue in Europe and North America, where the HPV positive oropharyngeal cancers, everyone's talking about de escalation of treatment. And there have been trials where de escalation has resulted in excess deaths in the experimental arm, where we've reduced the intensity of treatment. And talking to patients, what always comes across is that although, yes, they are concerned about treatment related toxicity and morbidity or their quality of life, the most important consideration for patients is cure. So that should never be compromised. That's their view. So and that's one point. And secondly, um, it's communicating with the patient and giving them that option. Because I personally, I've had patients who have refused curative treatment and completely understanding the implications, because they think that quality of life is more important than quantity of life or the life they have remaining. So I think communicating effectively with the patients and making them understand the implications is extremely important. And also involving allied health professionals in the consultation, especially speech therapists who are going to be closely involved with their rehabilitation afterwards, is extremely important.
Yeah, absolutely. So, what the protocol that we follow in our hospital, Shri, is when laryngeal cancer patient comes in and organ preservation is an option. While the patient comes and sees me as a radiation oncologist and my medical oncology colleagues, I always insist that we get a fiber optic evaluation of speech and swallowing, because even if there is a tumor which can be salvaged by radiation without actually cutting it open, if the larynx is already dysfunctional, as you know, I mean, there is no point in preserving that larynx, because then the patient will actually have worse quality of life. So having this team-based approach where you have a surgeon, a radiation oncologist, a medical oncologist, a rehabilitation specialist, a speech and swallowing therapist, even sometimes an ENT specialist, I think is very vital. And that's why I emphasize on our patients that whenever you choose to get any cancer treatment, please go to a cancer institute which has a comprehensive cancer care available and is working as one team rather than just one individual. Because we see this very often, right? They go to somebody and say, oh, you have cancer, you must get operated tomorrow. Let me book a bed for you, get admitted tomorrow, and we'll do the surgery tomorrow. So that is a fear tactic which is used, unfortunately, sometimes, and that leads to disastrous results.
No, absolutely. I mean, I completely agree with you. It's fear of the unknown. So because for someone who doesn't have medical background or doesn't have any medical people in the family, as soon as they hear the word cancer, uh, they're afraid because they don't know and scared, and so they take decisions under pressure from the medical professional because they want to get done something or want to have treatment as soon as possible. But what they don't realize is that for any cancer, a comprehensive workup of the staging and function prior to agreeing to a life changing treatment is extremely important. And this is what needs to be stressed, that even if they've got a advanced cancer, there are very few cancers that progress and kill people within weeks, which is how long it takes for a proper workup, including staging and assessment of function. So, my advice would be to wait, be patient until all the workup's done, and like you say, always try and have your treatment in a center or a cancer center that works as a part of a multidisciplinary team setup, which is very important.
Yeah. So, Ashri, coming back to our discussion about organ preservation, I think we could, for the sake of simplifying it for our cancer patients and people who are watching this podcast, we could sort of simplify it into, say, a very early stage laryngeal cancers and advanced stage laryngeal cancers. So, what is your treatment protocol for, and say, T1, T2, N0? So, cancers which are limited to our vocal cords, but not spread to any other part of the body like lymph nodes or anywhere else in the body. What sort of protocol from organ preservation point of view do you recommend?
So the way we look at it is the surgeon undertakes a microlaryngoscopy and examination, and for early laryngeal cancers, say if there say it's T1A cancer, which is confined to a single vocal cord, if the surgeon deems that he will be able to resect it with transoral laser, effectively getting a good margin, then that's the route we go down to. Now, the situations where this is not possible is if it is a very large T1A tumor involving most of the vocal cord, or growing forwards into what we call as the anterior commissure, and which is what you see as the Adam's apple when you look in the mirror. So if it's extending up to that, then we do not recommend surgery and go for radiotherapy. Or the third situation is where the surgeon feels that the access to the vocal cords is not adequate in order for them to effectively resect this tumor using laser. So that is when we go for radiotherapy in this situation. And if you look at tumors that involve both the vocal cords at T1B, or tumors that have grown either above the vocal cords into what's called the supraglottis, or below the vocal cords into what's called the subglottis, then our MDT would recommend radical radiotherapy. And the reason for that is that although the cure rates with both the approaches are exactly similar, some studies and also a combination of meta-analysis, which is combining several studies to look at outcomes, have shown that the voice quality could be slightly better if you have upfront radiotherapy for these tumors compared to surgery.
Yeah, and that's a very important point, because even when you preserve the organ, if your voice is really bad, then again the patients are very unhappy, and of course the tumor damages vocal cords are so very delicate. The tumor itself damages vocal cords, then a biopsy or a surgery causes damage, and then radiation further causes damage. So what I hear you say is basically a very good patient selection done by a conversation in the tumor board is essential to determine what sort of approach we should take. From radiation point of view, do you use sort of shorter protocols, or you use the conventional fractionations in these early stage patients?
We do use shorter protocols. So usually we use a 4-weekly treatment. So giving a larger radiation dose in every fraction or every day, and uh, 5 treatments a week for 4 weeks for early laryngeal cancers. That's what we would use.
Yeah. So we follow the same protocol, 4 weeks, 20 fractions, in some patients, 25 fractions. And the results are fantastic. I mean, the tolerance to this treatment is so nice, so good, because our radiation fields are also very small. So side effects are very, very limited. And most patients tolerate this treatment really well, because there's no chemotherapy added to it. It's just radiation, and the treatment gets over before they know.
That's correct. Yes. And if you talk about advanced laryngeal cancers at the other end of the spectrum, when we look at cancers that are invading into the thyroid cartilage, which is again the cartilage that you can feel, which is the Adam's apple, on a CT scan, then the chances of cure or having a functional larynx after radiotherapy, or a combination of chemotherapy and radiotherapy, which is what we would use, is inferior to having a laryngectomy upfront for these advanced T4A cancers with the cartilage involvement. But and it's illustrated. I mean, I'll give you an example of a patient. So I had a young patient who absolutely did not want to lose her voice, and she said she was willing to accept inferior control rates and a non-functional larynx. And so yes, so we went down the chemoradiation route, and she had an excellent response to treatment. The tumor went away, but 4 years down the line, during follow-up, she came into hospital and kept coming back with recurrent pneumonias. And when we assessed her uh, with our speech therapy team, it transpired that she was aspirating because she had a non-functioning larynx as a result of radiotherapy 4 years down the line. And then, therefore, we put a feeding tube in and put her nil by mouth. And then we had quite an interesting and serious discussion with her as to whether she wanted to keep her voice or she wanted to keep a swallow. Because with nil by mouth and a feeding tube, she couldn't eat what she desired. She was on liquid feeds, which again had significant effect on her quality of life, although she could speak very well at this point. So in the end, she decided that swallowing or eating was more important to her, and she underwent laryngectomy 4 years down the line for a non-functioning larynx, and is now fit and well and without any disease. So, I mean, it's important to consider these factors. So, this story just illustrates that for these advanced cancers, having a laryngectomy up front might be the best possible option. So,
Yeah.
because she was lucky in that with multiple admissions with pneumonia, she survived all of those admissions. But most of the patients who have laryngeal cancers, they are long-term smokers and have COPD. So, a single episode of aspiration and pneumonia can potentially prove fatal for these patients. So, this decision making is quite important at the other end of the spectrum as well.
Yeah. Yeah, once the thyroid cartilage is invaded, we never recommend, rightly as you said, uh, radiotherapy in these patients. We encourage surgery, and many of these patients then do need post-operative radiation
Absolutely,
if
yes.
the nodes and margins and the size of the tumor and all the factors considered. But we do see, say, T3 tumors, which are large enough but not too large that they need surgery upfront. And that's a very interesting space where earlier the recommendation was mainly surgery. And after the RTOG 9111, we are using more and more chemoradiation protocols in these patients. What has been your experience in these marginally advanced laryngeal cancers where radiation and chemotherapy is being used?
No, it's a really interesting question you asked me, because I mean, uh, although our MDT for T3 tumors would recommend chemoradiotherapy if they're fit enough, because once the vocal cords are fixed, which is a definition of T3, and there is a high risk of lymph node involved microscopic cancer in the surrounding lymph nodes, and hence uh, uh, for these stage 3 tumors we recommend chemoradiotherapy and not radiotherapy. But just last year, I was invited to be on this panel at the European laryngotology meeting in Dublin. And the topic for debate was the best treatment for T3 laryngeal cancer. And what came across is in a lot of European centers, um, patients are still advised to have what is known as a partial laryngectomy, which is not a total laryngectomy, but in the interest of preserving function, they just do partial laryngectomy and intense voice and swallowing rehabilitation. And the surgical colleagues who actually do this technique claim that it is very effective. Now, a couple of things to consider here is one, importantly, some of the surgeons really didn't bring up the fact that the risk of microscopic lymph node disease in these T3 cancers is quite high. So, along with doing a partial laryngectomy, they also need to do a neck dissection. And because laryngeal cancers are midline tumors, that involves neck dissection on both sides of the neck. So if you combine that with the partial laryngectomy, and majority of these patients will require post-op radiotherapy, this results in a significant morbid life after all of these procedures. Now, I think you know this, Prasad, with when treating head and neck cancers, and be it larynx or any site, we know that if you have double or triple modality treatment, the morbidity and the long-term toxicity is the worst. So if you can get away with a single modality treatment, be it radiotherapy or surgery, or a dual modality, either surgery followed by radiotherapy or radiotherapy and chemoradiotherapy, your long-term outcomes and side effects are much less.
Yeah.
So T3 is still a subject of debate. And just to add to that, the NICE guidelines in the UK recommend that as long as the laryngeal function is good, the T3 tumors, we should offer them radiotherapy or chemoradiotherapy. But as you mentioned before, if the laryngeal function is suboptimal, then they should go for a laryngectomy, because having non-surgical treatment results in a non-functioning larynx anyway.
Yeah. And again, to re-emphasize the importance of speech and swallowing therapy, I highly recommend our patients that they need to continue those exercises on a very long-term basis, because like you mentioned, that patient after 4 years, she had a dysfunctional larynx. So
Correct.
these side effects can crop up later on also, they need to be very watchful of these side effects. So that's really important.
So I think
If
counseling by the speech therapist, like we've kept saying, in terms of the motivation required for rehabilitation, I think patients don't really grasp that when they have any kind of surgical procedure as to the amount of rehab and required.
yeah, it's also very hard on them. I mean, it's really sometimes probably even frustrating for them that they have that almost like a disability, and then on the top of it they have to do so many extra things, so it's not really easy. One of the things that I do, Shri, here is I also run a cancer support group called We Can, and in this we have monthly meetings. We have a lot of patients joining in and conversations around it, and our hope is that then it sort of builds in a community where people support each other, and we encourage people to talk about the challenges that they have gone through and what worked, what didn't work, and how did they come over the challenges that they had. And I think to a certain extent it does help these patients to then feel motivated that okay, I need to continue doing this. And again, on every follow up I keep emphasizing on this importance.
I think
So
that's
that's
vitally
really,
important. I think because having groups or and meeting people who've gone through the same thing as you have is extremely important and helps people cope better with whatever treatment they've had. And talking to patients a few years after laryngectomy, because we had a patient representative when we did the NICE guidelines a few years ago, and he was a person who had a laryngectomy, and he did say that although for the first few years it was really, really bad. He felt that his quality of life was quite bad. He said, I did get used to it. And now he's found ways around in which he can communicate with people. He's undergone voice rehabilitation. And he says, I've come to terms with my diagnosis. And what helped him, he said, is belonging to such groups, which, which help support them because they've gone through the same kind of treatment.
yeah, indeed. So Shri, we spoke a lot of technical details about surgery and radiation. Do you want to sort of touch upon the chemotherapy part as well? Because now chemotherapy has become integral to treatment of laryngeal cancers, and then maybe later on you could also dwell upon the incoming role of immunotherapy as well into this.
Yeah. So starting off with chemotherapy, I think uh, again, hearing the word chemotherapy brings images to people's minds of bald people vomiting all the time on wards and not being able to eat, and stick thin individuals. But this is not correct, because both you and I know, having treated several patients who've had chemotherapy along with radiotherapy, the chemotherapy drug that we use, the platinum containing agents, are well tolerated in 90% of the people. And even in the other 10%, uh, there are pharmacological interventions which can prevent toxicity such as nausea and vomiting, and the incidence of hair loss is very low. So it's a very well tolerated treatment. That is the first thing to remember. And it has been shown in several clinical trials over a number of years in several thousands of patients that they improve the survival rates for stage 3 and 4 head and neck cancers across all tumor sites. And be it radical treatment or upfront chemoradiotherapy, or combining it with radiotherapy as the first treatment, or adjuvant or supportive radiotherapy that patients have after treatment for patients with or tumor pathology with high risk factors. Adding in chemotherapy has resulted in survival advantage for this group of patients. So I think it's a very good treatment. But again, as always, for any cancer, any patient selection is very important, and talking to patients carefully about the benefits and risks of treatment. Now, immunotherapy, yes, it's going to play an increasing role. Now, the trials of immunotherapy, combining it with chemoradiation for advanced, poor, kind of high risk head and neck cancers, were negative. But at the ASCO meeting that is just finished in June, there was a trial that was presented from France, the Gortec group, called Post-op Nivo, where they used a immunotherapy drug called nivolumab following surgery and in combination with radiotherapy, and for about 12 months afterwards. And that showed that patients live for significantly longer if they've had the immunotherapy. And although majority of the patients in this trial had oral cavity cancer, there was a significant proportion with laryngeal cancer as well. So I think that is going to be increasingly be used after chemoradiotherapy in trying to improve the cure rates from these cancers. And the other study that's worth mentioning, which had a small proportion of patients with laryngeal cancer, was the Keynote 689 trial, which was again presented at ASCO this year, which used what's known as neoadjuvant immunotherapy, which is 2 cycles of an immunotherapy drug called pembrolizumab before the patients had surgery, and then afterwards along with radiotherapy for up to 12 months. And that again showed that the rates of distant metastases, which means that the cancer spreading to lungs, bones, etc., was significantly lower in people who have received immunotherapy before surgery. But like I said, if you focus on laryngeal cancer, there was only about 15 to 20% of population in that trial had laryngeal cancer. But again, still worth considering. So I think it muddies the waters slightly because the nivolumab trial didn't have neoadjuvant nivolumab before surgery, whereas the pembrolizumab study did. So I think it definitely has a role in this setting, and that needs to be kind of clarified using further trials or analyzing the results from these trials carefully before we can start using it as standard of care.
We just last Tuesday in our tumor board meeting had a presentation on both these trials. My colleague, Dr. Sevanti Limaye, she's a big proponent of precision oncology. So she presented this data and we debated as to, from India point of view, how do we go about it and how do we do it? Many of us felt that the Pembro trial was a little impractical for us to use because, patients are so anxious when they get diagnosed with oral cancer, especially they're symptomatic. For them to agree to take 2 cycles of Pembro before getting into surgery, we felt was a little tricky. But the Nivo post-op looked like a more feasible protocol. But we are again still waiting to see more data and how do we use it and which patients. And in India, of course, the expenditure becomes an issue.
Exactly.
Because it's not covered by insurance, and these drugs are, from the Indian point of view, horrendously expensive. So it's it's a tricky situation. But we'll have to wait and see. I think the patents are also expiring on these drugs soon.
Yes, nivolumab.
So nivolumab.
That's why they've got out a subcut preparation now. But anyway, yeah. So we should have the generic soon in the market. So that would be
so the generics will. Yeah, I think by this year end, the generics will hit the markets and the price will drop, and then we'll probably see much widespread use for not just laryngeal cancers, but all the head and neck cancers. So let's see how that goes.
No, absolutely.
So we spoke in detail about all these modalities, but from our patient's point of view, would you like to sort of summarize the treatment protocols, say the organ preservation treatment protocols, as to which patient should go for these organ preservation protocols, and how, just so everybody is clear at the end of our conversation what we are speaking about.
To put it simply, so for really early cancers, which is stage 1 and 2 or T1 and T2, except for the really small tumors involving a single vocal cord, radiotherapy should be the treatment of choice. Although surgery is not unreasonable if you're willing to accept a slight quality of voice effect from the surgery. For T3 tumor, and what's important to remember is for stage 1 and 2 tumors, with surgery you do preserve the organ, to be honest with you. It can result in a slight functional impairment, but you keep your voice box and you can speak. But again, you must be prepared for rehabilitation afterwards and doing the exercises if you want to maintain the quality of voice. For at the other end of the spectrum, like I said, for T4 cancers, there's no debate. The treatment would be surgery followed by chemoradiotherapy and maybe post-op Nivo now, if we choose to believe the evidence from the post-op Nivo trial. And the T3 cancers, it's slightly contentious, but again, if you've got a functional larynx, go with chemoradiotherapy. And if your larynx is non-functional, then go for upfront surgery. And what's important to remember is it's not just the surgeon and the oncologist who are involved in your care, but also speech and language therapists and other rehabilitation is very, very important. And another thing, like I would like to stress, is for the oncologists and the clinicians, patient selection is very important before you offer them the treatment. And from the patient's point of view, it's important to understand and think about the long term implications of any decisions that you make in order to treat your cancer.
Yeah, brilliant. Shri, one of the other things that I wanted to bring in is once the patient decides that, okay, they're going to go ahead with radiation, the common question that they have is what kind of radiation, what type of radiation, which machine should we use, which hospital should we use? And then there is a lot of talk about proton beam because in India now we have two proton beams. One is in Tara Hospital in Actrek, the other one is with Apollo in Chennai. So patients do have this questions, and Professor Chris Nutting did the landmark trial, passport trial, which paved way for IMRT in head and neck cancer, and you were part of that study. So, what is your recommendation when it comes to treatment um, techniques and equipments?
So for early laryngeal cancers, I don't think it matters significantly what technique you use, because in a number of hospitals around the UK, people still use old-fashioned 3D conformal radiotherapy for a small field, and that results in excellent cure rates and outcomes. However, for younger patients, there can be implications in terms of damage to the carotid arteries, which lie very close to the larynx. So a case could be made for sparing the carotids by using techniques such as IMRT, either to a single vocal cord, which has got the tumor, or both vocal cords. And the early results that have been published with IMRT trying to spare the carotids look really good. So I think that's not unreasonable to have IMRT for early laryngeal cancers if you are young, and by young I mean under the age of 60, because symptoms from carotid damage only become apparent about 10 to 15 years after the exposure to radiation. So keeping in mind life expectancy of a 70 or 80-year-old, uh, IMRT does not provide any advantage in terms of because it will significantly put up costs in a health system like India. For advanced laryngeal cancers where you're treating the lymph nodes, IMRT or VMAT should be offered where possible, or if the patient is able to afford it. And it has got significant advantage in terms of maintaining your salivary flow afterwards, keeping your taste sensation, and also sparing the superior constrictor muscle, which means that you're able to have a better swallowing function after you finish treatment. Well, as regards the proton treatment, again, I think that's slightly contentious. Um, Currently, I mean, in the UK, we've had two proton machines for 10 years, and they've been commissioned for certain indications, and laryngeal cancer is not one of them. Because again, majority of the patients are over 70, and the only advantage I think that proton offers at present for laryngeal cancers is in terms of reducing the what's known as the low dose bath effect, which means unintended low dose to areas outside the radiation field is lower with proton treatment. Now, what this means is that this reduces or has potential to reduce the risk of radiation induced cancers. And once again, the risk of these radiation induced cancers only come into play at least 15 or 20 years after you finish radiotherapy. So, again, life expectancy and the stage of cancer should be factored in before kind of going in for the proton treatment just because it's the latest technology, or just because someone is trying to sell you a treatment that's really expensive uh, and is being used in other countries. So that would be my recommendation in terms of techniques.
So in India, Shri, as you rightly said, because the proton is now become the buzzword, everybody wants to do it. And unfortunately, we do see patients who are treated on proton for no good reason. And some of them actually land up with especially skin related side effects because proton doesn't have the skin sparing effect. Carotid sparing has become very important, I think. So I also use in early stage laryngeal patients, I use actually VMAT for carotid sparing. Um, Even in patients, we do see patients who need re-irradiations also quite often because of field cancerization and other stuff. There again, we are trying to protect carotid. We do 6-monthly Dopplers and keep a check. One or two patients, we in fact, in coordination with their cardiology team, have even done carotid stentings if we felt the flow was dropping because of the narrowing of the carotid, because carotid is so very important for the brain. I mean, if your carotid gets blocked, your brain, I mean, you'll have a stroke or you'll probably just not manage surviving. So yeah, these are very important issues. So Shri, this was a wonderful conversation about laryngeal cancers. And we spoke about why are we getting laryngeal cancers, and how do we treat them non-surgically, and the techniques and everything around it. So I think it's a very rich source of information for our patients. But where do we go from here? What do you see future for treatment of laryngeal cancers from the point of view of not just cure, but also from the point of view of prevention and maintaining quality of life?
Well, most importantly for prevention, smoking. Stop smoking, and do not drink excess alcohol, because we know that drinking and smoking together increases the risk of these throat and upper aerodigestive tract cancers, as they're known, significantly. So that's the most important thing for prevention. I mean, pollution is another factor. So, I mean, that's slightly tricky because you cannot really avoid going out. So, wear a mask wherever possible would be the recommendation if you are aware of highly polluted environments. And going forwards, I think immunotherapy will have an effect in terms of how long people survive after treatment for laryngeal cancer. And technology continues to advance at a rapid pace. So I've seen videos, or I've seen presentations at conferences in patients who've had a laryngectomy, where they've had these microchips. So first, what they do is they record their voice for say an hour or 2 hours, saying various things, and then they have a microchip installed at the time of surgery, which can then be programmed using your voice recordings to enable the person to speak and sound as they did before surgery. Again, I mean, such technological advances will push boundaries in terms of rehabilitating patients, and uh, push. I mean, not pushing, but convincing patients to have the right treatment, which can be laryngectomy for advanced cancers, because then using such technologies, you could enable them to preserve their voice. So I think things are going to move quite rapidly in the next decade or so in treatment of these cancers. But again, prevention, prevention, prevention. Smoking and alcohol. That's there's no no way around that.
There's no way around it. Indeed, absolutely. So thank you very much, Shri, for this wonderful conversation. And it's been a pleasure talking to you after we spoke after a long time. So
Yeah.
thanks a lot for sparing the time today.
No, absolutely. Pleasure to help. Thank you.
Thank you. And
Bye.
so thanks everyone for joining us today. I hope you found today's episode very useful. If you have any questions for me or Dr. Shri, please feel free to ask them as a comment on the video, and we'll get back to you with the correct information. Please like and subscribe to the podcast, but more importantly, do share this episode with people whom you care about. Please join us in this fight against cancer with us. Thank you very much for joining today. Bye-bye.